Well, welcome everybody, and thank you very much for joining us at our first ICMDA COVID seminar. My name's Dr. Peter Saunders, and I'm in St Albans in the United Kingdom. And Santhosh, who I'll be introducing very shortly, will be speaking from the India-Nepali border on our subject. We hope you're all enjoying your isolation and finding lots of exciting things to do. And our prayer is really that this seminar will help to encourage you and equip you and inform you about how better to respond to this crisis in low resource settings. So the International Christian Medical and Dental Association, ICMDA, runs webinars on issues relating to healthcare practice, leadership, and the current crisis. And they're free to join. You just need to register in advance, so do spread the word. Today's topic is the COVID-19 pandemic, reflections from a limited resource setting. And our speaker is Dr. Santhosh Mathew, who is the South Asia Regional Secretary for ICMDA and is also our training coordinator. Santhosh trained in internal medicine, and he works part-time as an internal medicine consultant in the Duncan Hospital in India. That's a 225-bedded hospital near the Nepali border. And as I mentioned, he's training coordinator for ICMDA, developing an online learning platform, and as the ICMDA Regional Secretary for South Asia. He's pioneered HIV and TB health care programs in marginalized communities, and he's involved in hospital leadership roles right across North India. He's married to Sarah, an anaesthetist. They have 2 children, and Sarah's just taken over recently the leadership of the Emmanuel Hospital Association in Delhi. So without further ado, I'll hand over to Santhosh to speak to us on the COVID-19 pandemic, reflections from a limited resource setting. He'll be speaking for about 30 to 40 minutes, and then we will take questions. You've all been muted, so what we'd ask is that if you have a question while he's talking, that you feed it in on the chat facility. We'll pick those questions up and we'll select what we think are the most relevant and helpful to deal with in the discussion time. So over to you, Santhosh.
Thank you, Peter, for this opportunity and time. What I would take you through is over the next 20-25 minutes, few reflections and more questions than answers on some of the challenges from a resource limited setting. I'm not talking primarily from India alone, but from our own interaction in the region and in ICMDA from other countries which are from a resource limited context. I hope at the end of 30 minutes, we'll have another 20-30 minutes to reflect on some of these questions and learn from each other by your own experience from similar settings. I would look at broadly four issues. One is the issue of prevention, the issue of mitigation of the pandemic by early diagnosis and quarantine or isolation, some aspects of hospital-based management and the challenges and health system, and some concluding thoughts over that. We would not look at the numbers. We all are very aware about what is happening, and I'm going straight to the issues. Let's look at prevention. Prevention is flattening the curve. There is a simple, straight framework which across the world, every country is using. We need to flatten the curve. And that has been the driver, the primary focus, and every country is setting in steps to flatten the curve. Now, what are the core strategies being discussed? We're talking about social distancing, which has been now turned into physical distancing, because it's no more social. Physical distancing and social engagement. Test as much as possible. Isolate or quarantine or refer if required. Definitely hand hygiene and respiratory hygiene. Of course, masks, at one point of time they said that masks may not be required. As of now, it's almost sure that masks are mandatorily required. Even CDC has come up with it. So what does it mean for social, when you mean social distancing? At this point of time, if you look across the resource limited settings, there is one understanding. Social distancing means lockdown and restrict to home. Now, what are some of the challenges? If you look at social distancing in cities where 30 to 40% live in urban slums or resettlement colonies, there is hardly a place to distance. And most of the infections in the developed countries have come in from household contacts. Also, even in villages where there is a single or two-room house with 6 to 7 people, 5 to 6 people living in the same room, how practical is the distancing, though lockdown might restrict some amount of transmission across families? The other question is how long? There's been a modeling from India a few weeks back looking at forecasting based on the data available, saying that a lockdown for 21 days might not help. A break and another 20, 28 days may not help. A much longer might help. None of us know. We don't even know whether this will come down and then keep going up and slowly coming down. But during this period of time of lockdown and social distancing, you're expected to ramp up your healthcare systems, improve your testing, test as much as possible, and then quarantine or isolate. But in many of the limited resource settings, health systems haven't changed, testing systems haven't come in. So what do you mean by lockdown alone? So from London School of Tropical Medicine, there was a study looking at alternative ways, saying that maybe a green zoning of the vulnerable. You know that the vulnerable are the elderly, people with comorbidities, the disabled, and many others who are vulnerable, whether we can green zone either at a household level or at a street level, or maybe even create a neighborhood level camp where elderly can be green zoned. Excellent thought, but let's look at reality. Reality in resource poor settings, limited settings is not well spaced houses. The best village in a resource poor setting might be something like this, with each house having 2 rooms next to each other. But 30 to 40% of any big cities would be slums or resettlement colonies. So realistically, this is not feasible. So there is also the understanding of red zoning of the infected, which also is impossible. So there is a third thinking whether we can blue zone some parts where people are okay, they can work, where the rest are zoned off. Excellent thoughts, but limited to only semi-urban or urban context. That's one of the reasons many countries have looked at high prevalence space or hot space lockdown. For example, in our country, a city, multiple hotspots have been identified and blocked off. But in a large country with multiple locations, infections are happening, where most of the contexts where there is no testing freely available, how do you decide where the hotspots are? Hotspots primarily would be where people come in through from flights or transport, but there are many interior areas where the community spread has happened, but there are no testing systems. I'd say, along with that, one of the other issues to look at is the whole universal hand hygiene and respiratory hygiene. A good number of villages in rural areas, in resource limited settings, does not have running water, which means we need to, on a raw food setting, look at developing alternative systems for hand washing, which means buckets, soaps. Similarly, we talked about respiratory hygiene. One of the challenges we face is when people are asked to wear masks, they think it's a stigma, because traditionally it is patients with TB or who are infected who have worn masks. And you are asking normal people to wear masks, they think that it is adding to their stigma. Another area to consider is the impact of lockdowns and this mandatory lockdown. 60 to 80% of rural communities in certain parts of resource poor settings like India, they are migrant laborers. They are caught between their temporary homes and permanent ones. They would work in metro cities, large cities. When the lockdown happened, they started walking home, 1,000 kilometers, 500 to 700 kilometers. But the province borders closed. So they caught in between, kept in protected zones. And they want to reach home, but they can't. But due to that, the problem is the unmeasured impact. They have lost their jobs, and they are daily wages laborers who do not have a bank saving. They have lost their food security. There are stories of people dying out of starvation because public systems are not in place. Many of them are a higher prevalence of infectious diseases, various diseases, high prevalence of TB, high prevalence of other illnesses. So because all the hospitals have been closed down, there is increasing morbidity. And definitely in the next few weeks, you will find increasing mortality due to non-COVID illness. And if you communicate and talk to them, I'm intentionally putting the us and the them because the leaders who take the decisions, which part of us, the privileged, we want to contain the epidemic, and our priorities are very good intentions that we want to maintain a social distance, wear masks, wash hands, protect the vulnerable, and we tell this should be done. But when you talk to these communities, they want to protect themselves, but their priorities for today, the money for today, what will happen tomorrow, and a desire to somehow reach their homes where they can find shelter. So what we are seeing is the pandemic of COVID has also, the steps taken had led to an epidemic of social disruption and worsening divide, an epidemic of hunger, starvation, and homelessness, panic and stigma, and increasing morbidity due to non-COVID illnesses. So we need, what are we learning? We need to flatten the curve. Yes, social distancing is important. Lockdowns are important, but were there other strategies better? We need to protect the vulnerable, but how can it be done? We need to take care, see that the disadvantage is protected. How do you develop the systems? And we are realizing that one size doesn't fit all. We should design what is best for our location. The frameworks we have continued to use is reduce the pandemic, reduce the numbers, flatten the curve. But in that context, somehow we are not done well in taking care of the people, the community, and the well-being of the people and community. So I think we, as a faith-based community, has a major role to play here as states try to reduce the numbers and flatten the curve. So something to reflect on: what would be the best prevention strategy? How do you protect the vulnerable and disadvantaged in the middle of this lockdowns and the impact of that? It's only possible if we develop an ability to listen and not to give technical answers. Listen to the community. Listen to what are the challenges they're going through. Listen to the voices that are not heard in the strategy and planning, and help them to protect themselves and set up systems of prevention. Let me go on to the second aspect of my presentation: mitigation and early diagnosis and quarantine. How do you test when there is no systems in place for testing? RT-PCR, to have, you need accredited labs with systems for RT-PCR. There are provinces or districts, whole districts, there's only one center which can do it. Large number of communities, population does not have ability to access testing. Quick testings through antibodies does not help in your management. It only helps in your understanding of what the prevalence is. So do we look at clinical protocols for diagnosis and preventive treatment and isolation, or do we hold on to saying that we need to ramp up tests? We know that ramping up tests may not be possible in the next few weeks to months. Across the country, across the world, from resource limited settings, very good examples of clinical protocols are coming out. This is something developed from Uganda, where as patient comes to the hospital, based on the history of fever, take a decision whether patient is tachypneic, high risk or low risk, and go on. Similarly, in our hospitals, we have developed our own staging of illnesses based on protocols, but these are hospital based. Recently, some academics put together a criteria based, a major criteria followed by a minor criteria. Major criteria in the context of a mandatory criteria of fever, in epidemiological setting of travel, or with visit to a crowded place, with four major criteria and 3 minor criteria, and other accompanying criteria. Of course, there is X-ray and leukocyte count here, but these are examples of clinical protocols being developed, which can be adapted for community-based diagnosis. Very important for us to look at, can we develop community-based diagnostic algorithms, protocols to make quick diagnosis. Subsequently, then what happens? Once you diagnose, do we isolate or make a mandatory quarantine? We are realizing that mandatory quarantine doesn't work. People are running out of quarantine. One of the things to remember is the stigma. Heavy stigma. In the last 48 hours, 3 days, we have had 2 deaths in our nation of doctors whose bodies were not allowed to be buried because of stigma against healthcare workers who died due to COVID, a fear. So we have seen it in the HIV epidemic. We saw it during the HIV epidemic, severe stigma in communities. How did we overcome it? We had home care. We supported people in homes, but that was a chronic illness context. It might not be relevant, but a support to the people who are quarantined is very important. What are we learning? 90% will be managed at home. We need to focus on that. We need to have non-testing based algorithms. Stigma has to be addressed, and there has to be a system to support those who are vulnerable and infected, and families, and those who are isolated or quarantined. The question we need to ask is, using the HIV epidemic experience, is it our role to explore, to come alongside in homes and get in touch? It may not be possible in the context of quarantines, lockdowns, but when it opens, being an accompanying community, to be there to support and walk alongside with home care, maybe a revised home care program for this season. Let me go on to the third point which I wanted to cover, was the hospital-based care. What are some of the emerging issues? What are we being told from the experience in developed nations? Set up COVID-19 hospitals, close down the regular work, provide home-based care, refilling of prescriptions for chronic illnesses, set up mobile service for regular medical problems, and have full PPE systems in place. We're talking about contexts where basic healthcare systems do not function optimally, where access to regular healthcare itself has been difficult, where morbidity due to non-COVID illness has already been high, and none of these are possible due to either resource or systems issues. How do you function? We have had incidents where states have taken over small state-based organization-run hospitals in hard-to-reach areas where there are no other institutions for COVID. What would happen to the rest of the community in the next 3 months? We may need to look at alternative ways. We may need to set up hospitals with respiratory isolation sections. Go back to the older model of the quarantine for TB, where we had TB wards, respiratory wards. Many of us are doing triaging and acute respiratory infection clinics. We may have SARI sections, but instead of COVID sections, it may be worth looking at exploring a respiratory isolation section and graded levels of protection based on your clinical protocols. Looking at re-engineering our institution, and then look at ways in which you can assess severity. Again, excellent models are emerging from the African Academy of Emergency Medicine and other nations, where simple criteria-based, clinical criteria and simple investigation-based scoring systems for severity assessment and deciding what level of management has to be done. Recently, one of our institutions did a GPS-based isolation, tracking of patients back to their communities to assess the risk. I'm not going to details of this, and then make a diagnosis and score to take a decision whether they are COVID or non-COVID, likely or unlikely, and whether they should get moderate or graded as moderate or severe. Then comes the question of PPEs. How do you look at PPEs? Now, most of the resource poor settings, the full PPE is not available. 2 months have passed. Most of our locations do not have PPEs. So the question to ask is, how do you think and plan in a context where PPEs may not be available, or what is available may not be adequate? we need to relook at our levels of care and decide what you will do in what level. For example, in acute respiratory infection OPD, you should not do a throat examination or suction or any procedure. If so, you might not need a full PPE. Similarly, if you come to an isolation room, you will not do either a suction, throat examination, or NIV or intubation. You might not require a full PPE. Whereas when you come to ICU, you will do everything. So you need a full PPE. So level of care-based PPE based on the availability to optimally utilize the available PPE might be what is required. If you want to look at some of the innovations, how PPE can be made across India and many regions, many institutions are making custom-made local PPEs out of raincoats, out of plastic bags, out of mica, out of all kinds of things. And there is a link to the Indian innovation site. But very important to innovate and look at how can you, without losing quality and evidence-based standards or developing evidence-based practices, innovate and create PPEs. Coming to critical care decisions, even in developed countries, critical care, the ventilator support is becoming difficult. This model was developed in UK, looking at if they have limited capacity, only fit and well patients will go into intensive care. If they have normal capacity, fit and well, even with those with comorbidities, might go into ventilated care. Where frail patients may not. But if you come to a limited resource setting, this might change. We need to look at models like this and work to develop our own standards and decision-making models. A limited number would be the standard. Limited number of critical beds or ventilators, which means majority would go into palliation, and a very few might be considered for critical care. If you look at resource-limited settings, in a normal context, anybody above 60 or 70 with multiple comorbidities are not offered critical care due to limited facilities. So decisions for COVID will not be different, which means you need to have much more stricter onboarding criteria, onboarding for critical care, which means we are actually talking about a distributive justice based on limitations in our facilities, which will lead to the next question, that palliative care. If the epidemic matures the way it has matured in the West, in developed countries, in resource-limited settings, a large number will require palliative care systems, which means that we need to retrain, plan, and reposition our teams which have been doing palliative care for COVID-19. Let me come to the last point and look at healthcare systems. We talked a little bit about this. There will be crossover, but there's some more things to consider. Most of the evidence which are emerging is from the 5 to 7% or 10% of those who are requiring critical care. But what about the rest 90%? That would be the burden which we need to consider also. What are the lessons emerging from the health system? This is an article written by 2 academicians in India, looking at the lessons, learnings emerging from the West, from the developed nations, that healthcare systems are being challenged. Hospitals are becoming reservoirs of virus. Healthcare professionals are becoming the vectors. And so healthcare professionals numbers are dropping. So they're suggesting that we need to consider the population as an individual patient and expect that some loss of life will be there. And majority should be managed at home with home oxygen if required. And look at developing complete, well-equipped COVID-19 centers. And they have gone on to use that to consider reflections for the resource-limited settings. I'm just sharing this as it is with no comments, though many of this may not be realistic. Shut down OPDs for chronic illnesses. Vulnerable people should not come. But what happens to the morbidity or mortality due to that? Telemedicine programs, home-based care, delivery of medicines, hotlines for support, test collections at home, syndromic approach which we looked at, appropriate home isolation, and tests only when required for care. Similarly, dedicated ambulance, separate emergency for ARI, model COVID systems, and separate hospitals for non-COVID. Every patient who comes should be considered as COVID positive and tested before, if required, before surgery. Now, good reflections, considerations, but practically how much of this will be possible in a resource-limited setting is something we need to consider. Somebody has, from our country, has put up this interesting map, graph, which looks at 4 waves. Actually, a wave of immediate mortality and morbidity of COVID-19, which most likely may not taper off, might go on for another 2 or 3 months as multiple small wavelets. But then the second wave will be the impact of resource restriction on urgent non-COVID conditions. The third wave would be the chronic conditions which have not been attended to during this period of time. And of course, the ongoing psychic trauma, the mental illness, the economic injury, and the burnout due to all the challenges of the footprint of the epidemic. Couple of days back and today, we have been in touch with resource-limited countries and talking about faith-based organizations. Because of the regular work being closed down, many institutions are at the verge of questioning their survival itself. This waiting period, there is no money, there is no revenue coming in. And the question is, will the not-for-profit institutions, say these organizations, survive this waiting period? So very important for at this point of time for us to reimagine our healthcare systems. There is an urgent job for here and now to take care of the immediate challenges, locally relevant, but learning from the challenges faced by resource nation. But not to get overwhelmed by what we are hearing. But there is a need to reimagine, re-envision for tomorrow. Healthcare systems will change after this is over. It may be an opportunity to look at technology-based platforms, telemedicine, online systems, reducing hospital visit, home care, and hospital systems to manage both pandemic and regular patients. It's very important for us as a faith-based community, as a larger community of people from resource-limited to start brainstorming, create brainstorming forums to envision the healthcare system for tomorrow, which are relevant for a resource-limited setting. Let me summarize and conclude with some few thoughts. So what did I share? I shared that prevention is important. We need to flatten the curve, but we need to protect the people in the margin. We need to listen to the people. We need to mitigate, but in a context where testing is not there, we need to come up with clinical diagnostic protocols that are community-based and explore how we can accompany people when the lockdown opens, maybe through home care systems. We need to innovate for setting up clinical care systems which are realistic and reasonable for the context we are. And we may need to reposition our palliative system and start re-engineering systems for today and envision for tomorrow. In the middle of all this, let's not forget that there is the mental health of everyone, the patient, the family, the healthcare worker, the larger community. Who will take care of this? Could we start exploring, raising up, training an army of counselors for tomorrow? And not to forget that our mandate is to care for the most vulnerable around us, among us. Innovative ways and use of technology. To do this, we need to cultivate a sound mind. This word sound mind is given in different ways in different versions in the Bible. Self-control, self-discipline, good judgment, sound judgment. But more than that, a mind under the control of God's Holy Spirit. Careful, rational, sensible thinking guided by the Spirit. And we need to recognize that we are privileged. We are kept by God as a privileged community who can understand the epidemic and understand God's purposes for such a time as this. And we need to be people who will know what to do in such context. Thank you. And I hope I've shared more questions for us to reflect, and over to Peter for the rest of the time.
Well, thank you very much, Santhosh, for an incredibly comprehensive treatment of a very complex subject. Amazing that you got through so much material in just half an hour, and I'm sure you've raised a lot of questions with people. Just a reminder to those who've joined us, there are about 100 of us on this call. If you do have questions, could you please feed them in on the chat line, and then we'll ask Santhosh to deal with those. So just one question first, Santhosh, a practical one. People are asking about the presentation and whether that might be available to people in the future.
Yes.
Via the website.
I can share it as an attachment in the chat, or if you send mail to the group, we can email it later. Both ways.
Yeah, I think we'll write back to the group after and leave a link to that. So
we can't hear you, Peter.
Our first question for you, could you share with this from Monica? Could you share with us India's effort in contact tracing and active case finding? And how do you see the role of community health workers in this?
They have not done well in sense of contact tracing in rural areas, whereas in urban context, it has been done well through urban health workers. Definitely, ASHAs might have a role, but at this point of time, with the lockdown, everything, including healthcare systems, are closed down. So only when it opens, it will happen. But the question some of us are struggling is, by the time, would it be too late? It is that this is the time to do active case finding, even in rural areas. But if you don't do it now, would it be too late? Definitely, ASHAs is the accredited healthcare worker, has a role to play.
Next question from Dr. Anak, who's asking, in this pandemic era, how do we utilize telemedicine platforms in order to meet patients' needs? And not only to meet their medical needs, but also to minister to them spiritually. Would you like to comment on telemedicine and the role it might play?
I think definitely telemedicine could have a major role to play, and many countries have suddenly decided to make telemedicine as the legal way to do medicine. Our country has just passed a law a week back, allowing telemedicine legally. But the challenge would be that urban context, semi-urban context, middle class possible, rural, interior communities, would it be possible? Again, only when the lockdown opened, it will be possible to set up the systems and get the message across. So those are challenges, practical challenges to think through. But I feel that definitely telemedicine would have a role to play if this continues for next few months.
Could you comment, Santhosh, on the role of the local church in prevention? Do pastors and church members who are not from a medical background have a role to play in helping to achieve prevention?
Definitely, yes. I think if in the community, in the local village or community, if there's a church, I think the church has definitely a role to play, both in terms of giving the right messages of prevention and also accompanying them in their homes by providing psychosocial support and even material and other support, definitely.
There's been a lot of talk, particularly in the UK, about the subject of herd immunity, when it was suggested that we should just allow this virus to run through the whole population so that everybody ended up with some immunity. What's your take on herd immunity?
Um, I'm not an epidemiologist or a public health person, so my statements will not be uh, uh, from a knowledge base, but in the last 3 weeks, leading epidemiologists in our nation from CMC Vellore, Christian Medical College Vellore, have clearly said that that is the only way to go in many of the resource limited settings. At the same time, protect the elderly and the vulnerable, because the ability to ramp up testing systems will not be there. So the herd immunity will be the only way to go. But the question would be, how do you balance protection of the vulnerable in the middle of that and reduce the mortality?
I wonder if you could comment on the practicalities of social distancing. How do you practice social distancing and regular hand washing in very poor societies with limitations in terms of water supply, potable water, and cramped living spaces? Now, you address this to some degree in your talk, but I wonder if you can unpack the practicalities a bit more.
Yeah, I think there are models emerging from some locations where communities have been taught how to use buckets and soap. African context, there are some churches we have developed skippy taps for villages with large containers and taps. Some of the hospitals have created foot switch based taps without hand touching. So there is this innovation happening in different places where alternative ways of hand washing has been done. But respiratory hygiene without masks in a crowded place is next to impossible. So masks has been, many places there are churches which are making masks and going into communities and giving, but physical distancing is not possible because there is no space.
I wonder if you might then comment a bit more on the use of masks. Now, the advice that's been coming out has been somewhat conflicted, with the WHO still recommending masks for people who are infected or who are healthcare workers, but not for others. The CDC's taken a more relaxed issue, and I know there are some countries like the Czech Republic, for example, which have pushed masks very hard for the general population and are claiming some success. So can you talk about masks for the general public in resource limited settings?
I think some of us have been talking about it to understand from the community perspective. If physical distancing is not possible, I think the only alternative is masks. But the question is, how do you get masks across to every house, every person, and how do you help them to get over the stigma of masks? In a context where physical distancing is possible, where crowding is not there, where people are able to keep that distance, I think you can use masks with restrictions. May not need to use masks, but otherwise, my personal opinion is mask is the only way.
I wonder if you could comment on the surge phenomenon. We witnessed initially in Western Europe, in Spain and Italy in particular, that the number of cases requiring intensive care or hospital care really swamped the existing hospital facilities. And so there's been a great emphasis on flattening the curve in Western countries. And that's worked to a large extent now, with many countries seeming to reach the peak and plateau. But can you talk a little bit about the surge capacity in low resource settings? How much are we expecting, and how could it be mitigated?
the capacity in resource limited settings to provide critical care would be very limited.
Because most people would just be having palliative care. Is that what you
Yeah,
mean? So
yeah, because and also the systems for ventilation and support to ramp up in such a short period of next 4 to 6 weeks. Most of the resource poor settings, if the peak has to happen, it will happen in the next 4 to 6 weeks. By end of April or begin mid-May, you will have the numbers in many of the resource poor settings if they have. To set up those systems in 4 to 6 weeks, train, get institutions now ready, it's next to impossible. So I don't think it will not be possible to ramp up the critical care systems the way West have done in resource poor settings. Urban context maybe.
So someone's raising the question, if you don't have intensive care facilities and you're in effect giving people palliative care if they're needing intensive care, then is there any point in poor resource settings of trying to flatten the curve at all?
Definitely yes, because if you don't reduce the number of infections, it will continue to spread. Now, if you're looking at the model of herd immunity with protecting the elderly, vulnerable, then you don't need to flatten the curve. But we are not able to protect the vulnerable. We are not looking at herd immunity as the answer as of now. We are actually looking at reducing the number. So if you don't do it, the number of deaths will be much more. So you need to balance. So I don't have the answers. Somebody else might have more clearer answers on this.
I don't know whether this is within your field, Dr. Santhosh, but can you comment about the rapid diagnostic test and its accuracy and usefulness and availability in poor resource settings?
The rapid tests are the antibody test which is available in a test come in the last week in some of the countries. They have become the IgG, IgM and IgG. The IgM becomes positive in 5 to 7 days. IgG becomes positive in 7 to 10 days. So average about 10 to 12 days, I think. That is it is not useful for a diagnosis of an acute infection. It is useful for a diagnosis of having had an infection. So in making a diagnosis, it may not be possible. So the current guidelines in India is if you have had more than 7 days of fever, try IgG rapid test. So to decide whether there is a community spread, IgG is an excellent tool. But the specificity and sensitivity, I'm not very sure because large number of studies haven't happened. So I'm not sure about the specificity and sensitivity.
Okay. Someone's raising a question about countries which have opted, perhaps like Belarus, not to go into lockdown for fear of what it's going to do to the economy. And I know there's been criticism of global south countries like Nigeria and India for adopting lockdown too early before there were many cases and potentiating all sorts of economic problems. Would you like to comment on that?
It's a very sensitive topic, and it's a topic in which we don't have the answers. Probably we will all be wise at the end of this epidemic when you go back and study each country. But having said that, I think countries had to take a decision based on the evidence they had, and most of the evidence was from resource-rich settings. And each country took a decision based on what they felt is the best. But I think my perspective is only one thing: you need to contain, but you need to take care of the people. The framework we use should not be epidemic control alone, but take care of the people and the community. Numbers should come down. At the same time, the vulnerable and the marginalized should be protected. So a model of both together would have been better in many countries, but we don't see much of that other than of one or two countries.
I wonder, just shifting to education now, in places where educational level is poor, and where people might believe either that the disease doesn't exist, or that it's caused by 5G, or that it only affects affluent, wealthy people who travel a lot. Can you comment on the Indian experience in educating rural populations, and what the best way of doing that is, and particularly perhaps what role the church might have to play in it?
I think many countries, including ours, have done very well in educating through, blanket coverage through every possible media, including cell phones. You start with a cell phone, you call a person somewhere, you'll get a message for about 3 minutes on COVID. All cellular operators, every TV, every media. Having said that, in the last 2 weeks of observing experience, reports coming out, the stigma seems to be more in the urban educated than in the rural poor. I'm not sure why it is. We have had the same issues in HIV epidemic time. The stigma was more among the educated urban than the rural poor. So the understanding versus how they respond to it. I definitely think churches have a major role to play in giving the right information, because there is also the alternative media, alternative messages going across social media, which is creating unnecessary panic. So I think churches have a role to give the right information.
What if we could go back to the question of masks again, and the type of masks, both for PPE and for the general population? I think one of the problems we have in the West is that we feel we have to do everything perfectly or it's not acceptable. And this has created big problems with supply of PPE, especially in the UK at the moment. But are you able to comment on the relative effectiveness of masks made out of different material, and particularly the use of fabric or cotton masks that could be produced in very high numbers very quickly by local industry?
Yeah. In healthcare settings, though most of the guidelines say you need to use respirators N95 or N99 for all patients, most of our settings do not have it. So what we have, like I said, if you decide on the level of care, I think you can decide whether you want to use a respirator, N95, N99, or a cotton mask. There are specifications for cotton mask, triple layered with a thickness required. If anybody is interested, if you can send me email, I can give you the specifications. I don't have it offhand, but we have clear specifications of what thickness of the cloth and how many layers, 3 layers can be done. For a regular household protection, a 2-layered thick cloth mask is good enough, but it has to be washed every day and dried in the sun. For example, I carry around 2 masks. Every evening I wash it, dry it, and use the next day. A double-layered cloth mask. But I don't go into the hospital where respiratory illnesses are being taken care of. But you need to look at that. Specifications that I can pass on later.
Dr. Santhosh, you said a lot in your talk about the need to listen to the people and to work with communities. I wonder, could you talk about the practicalities of this in India? How does one listen to the community? And To what length when it might involve delay in implementing important treatments or preventions?
Yeah, very important question and very challenging question. We don't have the answers because we are limited by very strict lockdowns. But in there has been places like, including where I am, where we have been allowed to go into the villages to provide material relief because people are starving. So those are opportunities to listen to the people. Uh, uh, Slowly, countries are realizing that if this continues, there will be much more starvation, and so they're opening up slowly. So we may need to look at, getting permissions from the state authorities to go in, listen, and then provide solutions. It is a challenge.
You raised the question in your talk about hospitals being a very potent reservoir of the virus. So people going to the hospital for something else and getting infected. And you talked about the importance of home care. Could you talk a little bit about how home care works in India and the best systems to put into place?
Sorry, it is just a concept which we have been talking about. In India, home care hasn't started for COVID-19 at all. We have started talking about it. It cannot happen unless the lockdown and the limitations are the lockdown opens. So we have started talking to our community health workers, the ashas and others, exploring this as an option. So we don't have the experience.
Now, another question about diagnosis. Given that bedside testing and throat swabs are not going to be available in sufficient numbers, we're struggling even in developed countries. You mentioned the importance of making a clinical diagnosis, and you gave percentages of the likelihood for various symptoms. Has that been implemented more widely? And in particular, are you aware of organizations like CDC or DFID or USAID or WHO taking up a syndromic approach to diagnosis?
Thus far, it has not been tried in large numbers, nor by big organizations, primarily because most of the work has been in developed nations where there are all the systems. Only small numbers and have been tried, and it's just being rolled out in some countries and some locations. I know that Uganda and some parts of Africa, they are trying out. In India, some institutions are trying out, but no large number nor big institutions have looked at it.
A lot of Western countries, in seeing this coming, put a lot of money and time into building their capacity for looking after patients who were moderately or severely ill with COVID. Is it possible to build capacity in low resource settings in a similar way? And if so, what's the best way of going about it? Are there any best practice models that you can point to?
I think for a country like ours, it's difficult to say, but there are locations where this is happening. As of yesterday, one corporate company has set up a 200-bedded hospital in a rural area and asked the Christian hospital to manage. So there are models emerging where corporates, faith-based organizations, and the government is coming together. But it's limited to small locations and small contexts. At a large scale, it does not happen. At a large country level, I'm not sure whether we'll be able to ramp up the way Western countries did. But there might be small locations where it can be done.
Thank you very much. Well, I think we've come to a natural end there because we've run out of questions, and I was also keen to keep the section to 1 hour. So just to thank everybody for joining us. Thank you particularly to Dr. Santhosh for a most enlightening presentation, and especially for the way that you allowed lots of time for questions and people to raise these issues, and also for the way you handle those questions. We've had, through most of the session, about 100 people present. A few have drifted off during the question times, but it's still 93, so it's been good that people have been held here. We will write to you all after this session and give you information about how to obtain the PowerPoint presentation. And you'll find lots more information on our website. That's www.icmda.net, www.icmda.net, where there'll be information about upcoming webinars. And we have at the moment 2 other speakers who have agreed to give talks on the whole issue of a Christian response and of palliative care, and we'll be publicizing details of those on social media, on WhatsApp, and on our website in the next few days. So please do watch this space. Again, thank you very, very much. And Dr. Santhosh, we're getting lots and lots of people giving messages thanking you for the talk. And but the final thanks goes to all of you who've made time to come along. And we hope that this not just informed and encouraged you, but also that you will have now some resources that you can pass on to others as we attempt to cope and deal in the best possible way with this great challenge that we're facing. So thank you very much. The meeting's formally closed, but please watch this space and do come back again next time. Thank you.
Thank you.